Hi everyone, thanks for coming. My name's Sunny. I'm the coordinator for the sexual health team here at AHCWA, and we have Veronica.
Hi, I'm Veronica, and I also work, actually I don't work in the sexual health team anymore, but I'm here today. Yeah.
Hi, I'm Lee. I work with Noni, and we're both educators for health professionals at the WA Cervical Cancer Prevention Program.
And I'm Noni, and I am a health professional education officer with Lee. We job share, and I'm also a midwife.
And so they're going to chat to us about cervical screening for clinicians and answer any questions that you have. And so after a little bit of troubleshooting, we're going to get into it.
Sorry about that, everyone. Okay. Firstly, I would like to acknowledge the Noongar people as the traditional owners and custodians of the land on which we work and pay respects to their elders, both past and present. And we work as a statewide service, but for North Metropolitan Health Service, and we recognise, respect and value the Aboriginal culture as we walk a new path together. Now, firstly, I'd just like to show you this beautiful artwork, which is our program artwork, which you may have seen before, and we do use it on lots of our resources and incentive items. And this artwork was created by a local Aboriginal artist called Nerily Binder, specifically for the WA Cervical Cancer Prevention Program. The key message of this beautiful artwork is that knowledge is hope into the future, and it depicts women living in WA who are coming together to talk about cervical screening and how to prevent cervical cancer. They see the message as being very important to all women, particularly their families and the communities, and they travel back, as you can see in the picture, to their communities and talk about how to spread the message so that other women know the importance of having regular cervical screening. Now, in the middle there, sadly, the empty space that you can see in blue is for the women who have since died from cervical cancer in our community, and that's because they didn't have access to regular cervical screening. The woman at the centre of the image is dancing because the HPV, human papillomavirus, which caused the abnormal cervical changes, was found early, and if she didn't have regular cervical screening and left untreated, the abnormal cells can lead to cervical cancer. So as I mentioned, the WACCPP, Cervical Cancer Prevention Program for WA, is a state partner of the National Service. And I know that there's been lots of webinars lately with NACHO, there's been 2, and then before that, the Australian Cervical Cancer Prevention Council, they had a couple as well. So if you have any questions that you haven't been able to answer throughout those webinars, please feel free to ask them at the end, and we'll have lots of time for questions. So our aim is to reduce cervical cancer incidence and mortality by maximising screening participation in WA. And if anyone wasn't sure or hadn't heard of this already, but Australia is on track to eliminate cervical cancer by 2035. Now, to do that, we need to do it all together, and I'll go through what equitable elimination means for WA in the next slides.
Okay, the cervical cancer elimination strategy is about who should have cervical screening, what is self-collection, these are some of the things that we'll go through, and what is self-collection option and how does it work? This is probably be our strongest message, Jim, which I thought was from the NACHO as well. And we'll also touch on why cervical screening is important. And I think that just that population base where screening is always where we're screening healthy people who have no symptoms so that we can detect things that might occur later down the track if we didn't have screening. So the 3 big screening programs in Australia are breast, bowel and cervical. So the World Health Organization were the first to put out the pillars of how are we going to get to elimination by 2035. And the 3 pillars they talk about are vaccination, 90% vaccination for all people with a cervix should be fully vaccinated. Screening, at least 70% of women screened using a high performance test by the age of 35 and again at 46. This is the WHO. We do screening for all women from age 25 through to 74. Yeah. Treatment, 90% of women who do have screening, and the small number who may be detected as having a pre-cancer abnormality will be treated. So we'll go a little bit into stats. Stats are a little bit boring, but we can be really confident that WA is really hitting our target of screening. We're tracking at around 68%, aren't we, with screening? Of course, some areas will be a little bit less. Even though we're a statewide program, we were very much driven by data. So last financial year, we worked a lot in the wheat belt because we knew that while the state average was sitting around 68%, some of the wheat belt towns were sitting around 54%. So as Noni said, this can become an order of inequality, because if you have good access to vaccination, good access to screening, you're not going to get missed out. So as we move towards elimination, we'll very much be focusing on those people who are less likely to screen or who are under-screened. And that will be Aboriginal and Torres Strait Islander women, CALD women, and rural and remote also puts people at an increased risk of reduced screening.
So we've just got some stats there on rural and
remote by remoteness, which indicates again how rural and remote becomes a bit more of a barrier for cervical screening. And that might be just because services are not available. There's only one male doctor in town. They're not comfortable with that doctor. And that's why we're really starting to talk more about self-collection, because it has the capacity to remove some of those barriers for women.
You can see how it fits with the lower socioeconomic.
Exactly.
It's like it mirrors itself.
It does indeed. And so cervical cancer and mortality in Indigenous communities, we know that, but you said this was recently updated, wasn't it?
Updated stat here. It used to be four Aboriginal women are 4.5 times more likely to die. That's been reduced to 3.8, but it's still not on par with the general population of 2.5. So we just need, elimination is actually less than 2 cases per 100,000.
We'll never get to eradication, because people say if we've eliminated this, what happens then is you'll do yourself out of work, and it's not. This work will be ongoing, because we will always be chasing the new cohort of women, and we need to keep this in the forefront of women's minds that this is a preventable cancer. It's the only cancer we know to date that is caused by a virus. So if we can detect the virus, we can protect women.
Yeah. And some of those barriers that we think people aren't screening for is that stigma of it being seen as an STI. And although the virus is of HPV is spread mucosa to mucosa, we do want to talk less in that STI space, because 9 in 10 of us are going to meet the HPV virus in our life, which is a lot of us, 9 in 10. So we want to remove that stigma of STI, any feelings of shame or nervousness in having the test.
Noni's right, we'll all meet it, but most of us will clear the virus. So even if you did have HPV detected, doesn't mean you're going to have cervical cancer. The thing to think about is prolonged infection. It takes a good 10 to 15 years of having a persistent infection for cervical cancer to develop.
And here we'll talk about the 2-pronged approach of prevention in Australia. One is the National Vaccination Program for HPV. And so that's usually given in about year 7, and that's through the National Immunisation Program. And I'll show you some immunisation stats after this. But the secondary prevention is through the NCSP, the National Cervical Screening Program. And that is a 5-yearly population-based screening program for asymptomatic women and people with a cervix. And that is free. And that is for all women aged 25 to 74.
So they're 2 of the pillars that the World Health Organization spoke about. So our 2 pillars that we're working from are vaccination and screening.
And it's definitely worth mentioning that the HPV vaccination is now only a 1 single dose.
Yeah. And Noni and I go and do a lot of education with rural GPs. And I think that's a real gap in knowledge with a lot of the GP services, that it was recently extended to age 26. So it's really important, if it's a 1 dose of human papillomavirus, the vaccine, the Gardasil vaccine, if you weren't at school on that one day, previously you could do a catch up with a GP, but it used to cost people. They've just extended that now to age 26. So if you didn't get a vaccine at school, you can go to a GP. It won't cost you. You might have to pay for the consult, but if you go to an Aboriginal health service, you won't, and you'll get the vaccine for free up to age 26. Much better to get it before you become sexually active, but still protective if you have it up to age 26 and you have become sexually active.
Yeah, and the good thing is we have access to AIR, the immunisation register.
Yeah.
So it's easy, much easier for us as clinicians to go into AIR now and to check if someone's had their
Fantastic.
vaccination.
Yeah.
And when you go into AIR via PRODA, there's also an addition that you can have for the National Cervical Screening Register. So that would be accessed via PRODA as well.
Yeah.
Yeah.
They can do it one-stop shop. You can see everything.
Mm.
So that's some stats there on HPV vaccine coverage. As part of elimination, we need those stats to be up near the 90%. So we're getting there, but as you can see, obviously it's not an equitable spread at all.
And we also would have migrant people coming in from countries where there is no immunisation program as well. So we will still potentially have unvaccinated people coming into the community. Yeah.
So now we've got a true or false question. I can't see everyone, but if you would like to say something, true or false, do people with a cervix who are vaccinated against HPV still require cervical screening tests? The answer, of course, is true. So there's over 100 types of HPV that affect, there's over 100 types of HPV. Over 40 of them affect the anogenital region. And the HPV vaccination called Gardasil 9, there is another one called Cervarix, but Gardasil 9 is most commonly used, and that is protecting against the 9 most harmful types. And just on the side there, I've got a bit of an infographic on what we're protecting against. It's not just cervical cancer. We've got genital warts, anal cancer, vulvar cancer, and a few other ones that you can read there. And as I mentioned, it's just one dose, and there is now the free catch-up. So it's worth mentioning again that HPV is spread through mucosa to mucosa. It does not have to be sex as we know it, just sexual contact.
And there can be sex toys, it can be not penetrative sex, just heavy petting, anywhere that there's been contact with mucosa to mucosa or genital skin to genital skin. Yeah.
Yeah. And we've got another true or false now. Women or people with a cervix who are in same-sex relationships, do they need to still participate in regular cervical screening? The answer is true. So the HPV virus causes over 95% of cervical cancers. And as I mentioned, it's spread mucosa to mucosa. So that is moist skin to moist skin, genital to skin. And most people will clear the infection within 1 to 2 years. I've got a bit of a better infographic down here for that one, which I might just skip down to actually. But the types 16 and 18 are most linked to cervical cancer, and we'll see later on the pathway, what kind of pathway that puts you in, a low risk, intermediate or high risk pathway. So this is just a quick stat about cervical screening coverage by age group. And just to show everyone that actually young people are doing quite well. They're up there in that 92%. And as we get older, that is when people are missing out on cervical screening. So it's really important that we talk to older women in our community, our aunties, our nans, everybody who might have not previously been in that last 70 to 74 age group, which has recently just been reopened again for screening for those women.
So it's only 5 years. 5 years ago, women stopped screening at 69, and then when we went to the renewal, we extended it to older women. So it's taken a while for that message to get out there. And it's interesting, younger women who are coming into the program are much more likely to ask for the self-collection option because there's been really good advertising campaigns around that.
Out of curiosity, are all the women not screening because of the sexual STI?
I think a lot of older women think, I've been through menopause. I haven't had sex for a very long time, or I'm just with one partner. So I'm not at any risk. But the interesting thing, the more we're learning about the human papillomavirus, is older women who have not previously tested positive are testing positive. And it's not because their partner has gone and cheated on them. It's because as our immune system gets a bit lower as we get older, the human papillomavirus can re-emerge. So for a young person, a positive human papillomavirus test is more likely a new infection, whereas for an older person, it may be a reoccurrence of an old infection. And I think that's really important to talk about with older women, because it could make them go home and accuse their partner of having a new partner, and it's not. It's more likely to be an old infection reoccurring.
I think that's an important message,
Yeah.
particularly when you look at the age group that are missing out.
Yeah.
And also I think having that self-collection option for that age group is great as well. For many women who are a bit older, it's not comfortable to have a cervical screen,
Yeah.
even to get up on the bed. And, you know, if you've got hip problems and or you're overweight and it's, the beds aren't that great, it's not an easy task for both the woman and for the clinician.
Yeah, that's a great point.
Yeah. And lots of women who have had a hysterectomy, so they would maybe had a hysterectomy 20 years ago. We meet these women at community events. They go, oh no, I was told I never need to have. But we always direct those women back to their GP, because it's the reason why you had the hysterectomy. They may have had a hysterectomy for a benign reason, such as fibroids, or they may have had a hysterectomy because they had a high grade. So if they had a high grade, we would recommend what we call an exit test, where they have one test to see if the human papillomavirus is present. And you're right, they don't need estrogen or anything like that, because the self-collect is such an easy test to do.
And so this is just a bit of an infographic about the persistence, progression and regression. And that is when that dormant virus that maybe has been there for a long time can resurge when people do have lower immunity than usual. And so most people will naturally clear the infection within 1 to 2 years. Most of us will. However, some people, that infection will persist. And that's why we ask people to come back and retest in 12 months, etc. We'll look at the pathway for that later.
And just on that point of immunity, any person who is immunocompromised, so might be taking some steroids for arthritis, or they may have had chemotherapy for another type of cancer, because their immune system's a little bit weaker, we would not screen them every 5 years. We would screen them every 3 years, because they've got less ability to clear a virus if they were unfortunate enough to contact it.
And can we screen those people with self-collection?
Yes.
But just more regularly?
Yeah. Yeah.
I've mentioned it down a little bit lower as well, but this is just going through the renewed program. So that's the program that we've had for the last 7 years now.
It is 7 years.
Yeah.
I'm still saying 5. It's 7, isn't it?
And so that's definitely the change from the terminology of pap smear now to the CST, cervical screening test. And we went from 2 to 5 years, and we have that HPV testing as the primary testing, which is shown to be more accurate. And so we've also opened up that age group from 25 to 74. We are starting screening that little bit later because of what we now know about the HPV virus.
Because we used to ask women to come and have their first screen at age 18. But even if we did detect HPV in an 18-year-old, the chances are they're going to clear it within 6 months or 12 months. So it was unnecessary screening and worry for younger women.
And so this is just another infographic that you might see in some of our pamphlets and things like that. And that is when you're comparing your screening options. The clinician collect with the speculum is actually one that can be reflexed for pathology. But if you do collect your own sample or you provide that to one of your patients, you just need to be adequately counselling them that there is a potential that if they are HPV positive or they do have HPV type 16 or 18, they will have to return for a speculum with consent and a clinician collected sample of the cervical cells. So when you take your own sample, we're actually only looking at the fluid from the mid-vagina. We're not looking at cervical cells. But if there is some HPV found, depending on the type or the pathway that you're on, we would get you to come back and have a speculum exam and would take those cells and would send them away for cytology.
And the chances of women being called back are pretty low. So only about 10% of people who were screened would have human papillomavirus indicated. And then the really bad ones, type 16 and type 18, is only about 2%. So Noni's right. The first thing we do with a clinician or a self-collector, it doesn't matter. As soon as it goes to the path lab, the first thing they ask is, did we see human papillomavirus, yes or no? If it's yes, they go, what type did we see? And Noni will talk about this more, but if it's a high risk, 16 or 18, they might send you for a more specialist service. If it's a medium risk, they'll ask you to come back to the GP to have a speculum put in. But with the clinician collected, they've already got those cells, so they can just go straight on. So even if women do choose self-collect, the chances of them getting recalled are fairly low.
So now I've just got a couple of slides about screening in pregnancy. And this is super important because pregnancy is sometimes the only time that women are going to intersect with our health system. And it's a very holistic time when we look at all of the different services we can offer somebody. And screening is one of them, cervical screening. So it depends whether what pathway you're on. We've got there the one-off test that can be offered for anyone who has had early sexual contact. Early sexual contact is defined as less than 14 years old. And then we've got women who may be on an immune deficient pathway, and that's 3-yearly testing. And then we've got women who were exposed to diethylvistrol, DES, in utero. And mostly those women know who they are. They've known about it their whole life. And it's a very, very small percentage of the community.
Is the DES, that percentage would be getting even smaller
Even
now
smaller.
because it was that long ago?
70s.
Oh, in the 70s.
70s, so they are 50, those
Okay.
women. So the DES daughters are 50, so they'll still be in the screening program for another 20 years, and then we will see that real drop off. So dethamisopristol, there's always one word, was just a synthetic hormone that was given to women in pregnancy in the 70s, and we knew that the daughters of those women had an increased risk of cervical cancer. So very much a specialist group.
So just in terms of pregnancy and screening as well, we've got a few different sampling instruments that we can use safely. Self-collect is safe, and to have a clinician collect is safe at any point in pregnancy. Just counselling women that there can be just a tiny bit of bleeding, and that obviously causes a lot of anxiety when you're pregnant. So having that adequate counselling first is essential, but it's not appropriate to use the endocervical brush, and that looks like a pipe cleaner on the end of the stick, and that one is not appropriate in pregnancy. So we'll just have a look now at a healthy, normal transformation zone. So just there on the right, the transformation zone is where the squamous and columnar epithelial cells join, and that is where the problems usually grow, right in that zone there, that transformation zone. If you'd like to know any more about this, we've got some great things that we can send out, and we've also got some resources which will show you what a normal transformation zone looks like and how it changes across a woman's lifetime. Here, this is an important slide we've found, haven't we?
We have.
In how to fill out a pathology request form appropriately. Now, at the top, it's really important that you capture it's not actually worded appropriately, and we're trying to have that changed, but is your patient of Aboriginal or Torres Strait Islander or both? And you just need to write on there, has this test been self-collected? That really needs to be spelled out. And what kind? Is it a self-collected HPV test? Is it a clinician-collected CST? Or is that patient symptomatic and you are ordering a co-test?
And some clinicians will even, if a woman has a disability or she's not comfortable doing self-collect herself, a clinician can do it. So if you're a nurse working in a nursing station and the woman who's there wants you to do it, you can do it for her, but you would still write that it's a self-collect.
I mean, the clinician can do the
The swab,
lower vaginal swab.
yeah,
Instead
and
of a full.
yeah.
regular exam.
So we can still assist people who want to be assisted, and it's just important that we don't indicate that that's not a self-collect.
And sorry, what is co-test?
A co-test is what Noni was talking about with the
Symptomatic.
the reflex PCR,
Mhm.
the reflex the old pap smear.
Yeah.
So we've clinicians put a speculum in. They've
Yeah.
taken cells from the transformation zone because we want to know what the cells are looking like. That's
Yeah.
a co-test. So looking for HPV, but also looking at the cells.
And you put it in thin prep. I
Yeah,
imagine.
yes.
Yeah, there's two methods. There's a dry method and there's a wet method. We'll show you a resource that we've developed, which we hope will clear up all the confusion about the two methods.
And this on the side, are we supposed to, a clinician supposed to make sure that's all filled in for?
Yep.
If possible, it's great that you can fill in that side there. And of course, that question up the top, when we know that there is such a disparity between the incidence and mortality with our Aboriginal women, we really would like that to be checked. And we're really working hard on that because we want to close that gap.
And we need to have that data to
Mhm.
argue for
Funding.
funding. Yeah.
Yeah.
Mm.
So now we'll just quickly go through the signs and symptoms of cervical cancer. I know a lot of people are probably aware, however, they are any abnormal vaginal bleeding. So this is after you've had intercourse, between periods, or after menopause. After menopause is not normal. Have it investigated, and definitely talk to your GP about having a cervical screen if that isn't mentioned in that follow-up. Any abnormal vaginal discharge for you. Only you will know what that's like. Deep dysmenorrhea is deep pelvic pain, so deep unexplained pelvic pain. And it's also important to consider non-obstetric causes when a pregnant woman in your care reports vaginal bleeding.
And also, cervical cancer can have no symptoms whatsoever. So Noni's right. After bleeding after menopause, we define a woman has been in menopause when it's been 12 months since she's had a period. So there can be some kind of intermittent bleeding, maybe a month, and then miss for 2 months and then bleed again. But if it's been 12 months without any bleeding and you started to have vaginal bleeding, I would definitely have that investigated. And the pain one is one that also a lot of GPs will ask about that because postmenopausal women might find sex uncomfortable because they're dry, but it's not that pain. It's that, like Noni was saying, it's the much deeper sort of abdominal pain that they're experiencing.
And so this is the current cervical screening pathway. You can access this via the Cancer Council screening guidelines. And that is showing you in a flowchart way of what the low, intermediate and higher risk pathways are. And it's really important to look down at the changes to the intermediate pathway, which I'm sure now are not so new and that you're all familiar with. But if anybody ever needs got advice or guidance on this, you can always reach out to us or a doctor in your region and get some clarity on that.
And always use a digital copy because I've been going to GP practice where they've got a really old one. Someone's printed it and laminated it and put it on the and Noni's right. So in the green, we've done a test. Did we find the human papillomavirus? No, you're good to go for the next 5 years. And in the red, it's pretty easy too. Did we find the human papillomavirus? Yes. Was it one of the high risk ones? Yes. So that tends to go straight to a colposcopy. But it's in the middle where it's those intermediate risk. We give women time. We give them 12 months to clear the virus. So we might say, come back in 12 months. And sometimes that can be a self-collect. The people in the little grey box, I don't know if that's clear enough for you to read. They are a little bit different. So that's any woman who's over the age of 50. And that's because their transformation zone goes a little bit higher up into the cervical canal. So we're never sure if we can get endocervical cells. Aboriginal and Torres Strait Islander women will give a deeper consideration to because of the increased risk. And any woman who's been overdue for screening by at least 2 years, we might just say that her risk is a little bit increased because we don't know how long that infection has been there. So it's a persistent infection, so they might have a different pathway. And we've had a couple of unusual ones that weren't on this pathway. We've had queries of a woman who had some low-grade changes, but no HPV present. So that would be just treated as a normal without human papillomavirus. That those changes could have been caused by thrush, inflammation. So even though it's not on the pathway, we would treat her as a normal. But you can always talk to the pathologist at the lab that you use, and they can give you that information.
Now, this is how to access the NCSR, that National Cervical Screening Register. If anyone has any questions about that, please reach out to us after this, and we can help you. And I'm just conscious of the time, but we'll go through the who, the when, and the where, and that is all women and people with a cervix aged 25 to 74 are invited to screen. When will they be invited? Oh, sorry, I've just not kept up with that slide. So that's the who.
Yeah,
We've got the when, and that is every 5 years.
Yeah.
Unless you have symptoms or need a follow-up test.
Then you get it sooner.
yeah, and it's funded. So
Oh, okay.
yeah, it's all about funding. So you say I'm due for my next test in 3 months' time. I'll get my letter today. I've got 3 months to have my test. And then another 3 months goes by, they'll send me a reminder. So people are turning up a little bit earlier. Sometimes they're anticipating it, and sometimes that won't be funded. But if you have symptoms and you need a test and it's not within your 5 years, of course they pay for it because you have a reason to have that test. It's not population screening anymore. It's become more of a diagnostic test.
Yes.
I imagine that's very important to put on the pathology request form that they
Yes.
added them.
Absolutely. So the person does not get charged because this has got, the person has symptoms. So we're doing a clinician collect HPV with a reflex liquid-based cytology.
What about if a woman comes in like a month earlier than when she's due after 5 years? Is she going to be charged for that?
No, the doctor will usually talk to the register through the Proda account, and they will negotiate that.
Because that happens. It's only every
It's we've
5
heard
years.
about it,
Yeah, and why would you miss that opportunity
Right,
to
okay.
screen that person? Yeah,
So there's been a little bit of an allowance put in there.
Yeah.
Because
good.
we did have people saying, I've been charged and I went in a
Oh.
couple of
Yeah.
weeks early.
2 weeks early, and we're punishing those who are doing the right thing.
Yes.
And we're also trying to, if a woman is recalled, we
Yeah.
usually set the recall a little bit earlier so that way
That's
Yeah.
fine.
They've got time to plan.
Correct.
Yeah.
And get into the GP, etc.
Yeah.
So this is, oh, sorry, that's just a little infographic of where you can go for screening. There's definitely lots of options, and they just keep getting bigger and bigger. So lots of options and lots of choice. And we want people to feel, like they've got a choice in all of this. Now, we're just quickly going to go through our resources. This one is our cervical sampling card. And did you bring one? I did. And you can order these through us, and we'll put the link into the chat.
These are all vaginal.
And we have a new resource after that. So this one was launched a couple of years ago, and we've gradually been updating it, but it shows you there pictures
Here we
of
go.
normal cervixes, and what's not normal.
And I think this is a really good resource because if you think about it, young clinicians aren't getting the same opportunity to see as many cervixes as they would have when they were doing pap smears on women every 2 years. So things that looked abnormal actually might be quite normal. So this is a nice sort of little guide, but more importantly on the front gives lots of details for them about pregnancy, what instrument to use, how to prepare a thin prep. So a little quick reference guide, and most GPs say they love these and hang on to them forever.
And they are designed to be able to be wiped over as well.
Yeah, and sometimes used as a teaching aid for a woman. If a doctor says, well, you've got a large ectropion, what does that mean to the average woman? They can show them a picture so they can show them what they're talking about.
This is our newest resource. Lee developed this one. And this is our vaginal sampling card.
And this one, we sort of tried to make it like a sister resource because we were beginning to realise that there was lots of confusion in the GP land about a self-collection. So we talked about the collection devices. We made some special notes about pregnancy, that self-collection is definitely safe to do in pregnancy and is probably preferred. And like Noni said, what a missed opportunity that we don't offer self-collection at an antenatal appointment. The diagram in the middle is just to help the practitioner discuss with a woman what they do, and then they can give them a handout that they can take in their little pouch to the toilet or have it laminated in the toilet. Sample preparation was a big one. So there's two versions. There's just that dry swab, which you hand to a woman. She does a quick couple of turns in the lower vaginal area, hands it back to you. The wet one is the Roche validated, and this will just depend on what pathology service. So the woman does exactly the same thing. She just does the dry swab, but hands it back to the clinician, who then puts it into the thin prep vial and swizzles it around to get the cells off. It doesn't leave the swab in there, and that's how it's prepared. The setting is discussed again up the top of the right, because we're a bit worried about women being sent home with this to do at home. We think it's much more likely that the patient's going to be compliant if you offer them to do it right there and then, because you can fill out the form. I mean, filling out those little details on a tube is a bit tricky, and if you work in a clinic where you don't print off an addressograph label, I wouldn't be relying on my patient to know what to write on that. Plus, we all know we can get given something by a doctor, go home, chuck that on the kitchen counter and I'll get to that, and you don't. The swab is stable for about 28 days. So if a doctor ordered it today and I didn't do it for 2 months, by the time it got back to the pathologist, if I haven't dated it, they'll think, oh, that's out of date.
And they may reject it.
And they might, yeah. So it's a real missed opportunity.
And it is in the cervical screening policy as well that we should be offering this in clinic. And just only taking it home under special circumstances and under the guidance from a doctor.
Yeah.
So if you can get it in clinic in a private space, the toilet, like leave the room, close the curtains, and just let a woman attend to that. Pop it in a little pouch. I know that some of the archers will be receiving a little pouch soon, a little
Pencil case.
Yeah, pencil case to keep it in if there's any kind of shame around having that. And also just, making sure that people feel comfortable and warm and safe and private.
And even just letting them be behind the curtain in the room, so you can say, "You okay? Can I help you with anything?" So they feel supported.
I think the times when we would try, I mean, because you could do the same with self-obtained lower vaginal swabs for STI testing. The time that if that goes out the door with them, then you're not likely to get it back. We all know that. I think that, and getting them to do it, and it's that quick and easy. And often people want to use the loo because they waited so long. So while you're here, just go and collect it. I think that,
If you've got any questions, you can come back and ask, and then return to the toilet. And it's just so much easier, and that chance of receiving it back and getting a good sample that's not been heat affected or anything like that is so much higher.
Menstruation was another one on that, because remember the old pap smear, if you were having your period, that encouraged you to come back at another time because the blood cells would mix with the cervical cells. Menstruation with a self-collect for a human papillomavirus, not likely to upset it. So don't miss that opportunity. Take the swab then, even if the woman is menstruating, because it's very unlikely to affect it.
I don't think that's a good point.
Yeah, and on the back of the vaginal is just a couple of really important bits about, just to remind you who can have it, who can't have it. So who's eligible, who's not eligible on the back. So really quick guide for a clinician if they're unsure. And this really helps having that conversation with the woman.
I love that.
Yeah.
Yes, that's our newest resource. And then we've got our beautiful cervical screening flip chart, which if you don't already have one, you're more than welcome to order one. And this is a resource for talking to women in your community. So it has a side that faces the client and a side that you can read from. And it's got some beautiful infographics, maybe not this one, but there's some much nicer ones about options, how to talk to your clients about cervical screening, who should have cervical screening, and everything like that. So this is the side that you would show in the clinic, and this is the side that you would read from. And so everyone's welcome to order some of our resources. I will put the link in the chat. And yeah, if you don't have one of these, they're great. It's been specially developed for our WA women.
Yeah.
Oh, sorry. And just if you would like to have any clinical education and training, they are hosted by Sexual Health Quarters. And then you've got that NCSR number just there highlighted that you can actually call to receive results for yourself or for anyone in your care.
And the sexual health quarter, that the learning modules is quick little module you can do online on self-collect. So it might just reinforce some of what you've heard here today. If you get a moment, go and use that link. Noni will share these slides with Sunny.
Thank you so much.
Oh, that's
Thank
Thanks
you.
for having us.
Stop sharing so we can. Does anyone stop sharing? Thank you to Rachel and Joanne. Do you ladies have any questions?
No, no questions. Thank you very much. It's been very informative. Thank you.
Oh, great.
Thank you.
That's
Thank
great.
It was great. I have a quick one, sorry.
Don't be sorry.
I was always a bit confused with the early sexual contact testing. When would you recommend would be a good time? Because we get quite a few 13-year-olds.
Okay. So there is, that's a really good question and something that we're definitely talking about more and more because a lot of people didn't know that this was an option. So before 25, if you have a client that has talked to you about this, you can offer them a one-off test between 20 and 25, and that is funded by Medicare. So it's not going to cost them anything, and it's just a peace of mind.
Is that even if they started 7 years before or at 13 years of age?
Yes,
Yes.
yes.
Okay.
And
Yeah.
we, unfortunately, we know that there can be early sexual contact that's not wanted. So also young people have become sexually active early before their vaccination, but haven't told their parents. So there is that risk for that persistent infection, but keeping in mind that young and they've got a really good immune system. So the chances are they have probably cleared it. But for peace of mind, there is, like as Noni said, there is funding for a one-off for someone you were concerned about.
And if I recall correctly, they've moved it because when they were doing the testing earlier, they were finding the infection and intervening.
Yes.
Exactly, we were
And
over-treating.
Yeah.
So we're in this lovely place where we've been vaccinating whole cohorts of young people. So there's a lot of immunity now because of vaccination. We know more about how the human papillomavirus acts. So we know the persistent infection. And if there's one take-home message, the increased risk of not clearing the infection, the big one is smoking. So people who smoke tend to have a more persistent infection because their immune system's always just a little bit under par. So it's another good incentive to stop smoking.
And another, just leading off the back of that is if you have somebody that you are looking after who has had early sexual contact and they have symptoms, completely different pathway. You just do that co-test with consent, but you offer that co-test if somebody is symptomatic because that definitely needs to be investigated. Yeah.
And we also have a wonderful website at the Sexual Assault Referral Centre, and we have it as well, which is a sensitive practice request form. So if somebody has some trauma around previous sexual assault or trauma around a previous pap smear that was uncomfortable, you can offer them a sensitive practice form, which just empowers them to be in charge. They say who can treat them. They can say, I want you to stop now because this is not comfortable for me. And I think just the fact that you have that available and you offer it to a person kind of says, we're working from a trauma-informed model and we're here to make this a good experience for you, never a negative experience.
That's great.
Yeah.
Yeah, that's so important.
It is, because we know that is another barrier for women who don't want to come to a medical service because
you don't want to make it worse.
We don't want to make it worse, we want to make it better. And again, empowering women that if they come asking for a self-collection and they have no symptoms, that's their right. If the clinician is not educated enough about self-collection, they can just say, well, I know that's one of my options. I prefer to do a self-collection. Thank you.
Yeah.
Yeah. And if you don't get the result you want, go somewhere else if you have the option. Yeah.
Thank you, everyone.
Thank you.
Have a good day.
Any other questions?
Any other questions, ladies? No.
I have one.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, guys.
Oh, sorry, Joanne, do you have a question?
Oh, you got a question?
No, all good, thank you.
Before.
All right, Joanne.
See ya.
Yeah, no, just about the co-test. If you do a pap smear, a clinician collect,
Yeah,
and you haven't put anything else on the form to alert the pathology to do a co-test, perhaps the patient's symptomatic and it's not mentioned, could they then just do, they look for HPV, it's not there, and so they don't go any
no,
further.
don't go any further.
Yeah.
So that's important, isn't it?
And
Really.
it's cost because without the presence of human papillomavirus, you're very unlikely to have any significant cervical changes, because human papillomavirus, particularly 16 and 18, are responsible for 95% of all cervical cancers. There's some really rare cancers. They're the small cell cancers that aren't caused by human papillomavirus, but they possibly would not have got picked up with the old pap smear anyway. So as we move into the future with less and less people having changes because of vaccination, the rarer ones will emerge more into the research, and they will look more prevalent, but it'll just be because it's less of the human papillomavirus.
Yeah, that's a good point. Yeah.
So it's there's no point to take cells from your cervix if there is no symptoms and no human papillomavirus. If there's symptoms, definitely. Yeah.
And it goes without saying, if you have symptoms, don't wait for the 5-year screening, go in as soon as possible.
Yeah.
And I think we were saying, but I think it was before we started, that if a patient has no symptoms, but they would prefer a clinician collected sample, then they're entitled to that.
Absolutely. And women may want the clinician to look at their cervix because they just feel comfortable that somebody has looked at it. And then there are some benign conditions like polyps and things like that, which women may want to have investigated. And that's some of some of these gruesome images are actually quite normal. And some cervixes can look abnormal because a woman's had a previous treatment. And it's your right to ask for a clinician collect. Yeah.
Right.
Sorry that we went so far over time. Sorry, everyone.
Yeah,
That's all
that's
right.
our fault for the.
Thanks so much for joining, Rachel and Joanne.
Yes,
and,
thank you.
we will send this recording out to you guys so that you can share with your colleagues.
And we'll also send links to the resources that you can download or order.
Yeah. So the bite size became a little bit of a meal.
Yeah.
Thank you, everyone.
Thank
Bye.
you.